Thanks everyone for joining this morning at the October 22nd edition of Nephrology Grand Rounds. This morning we have two speakers. The first half hour we'll hear from Dr. Watnick, and following that we have a guest speaker from the University of New Mexico, Dr. Larissa Myaskovsky, and I'll introduce her a little bit more later. So without further ado, Dr. Watnick.
Great. Thanks so much, Matt. I'm going to share my screen and then get into presentation mode. We'll get going if that works for everybody. Okay, let's put this into presentation mode. Slideshow. And I will change the display settings.
Actually, you had it right the first time.
I had it right the first time. Let me go back to where we were. Does that work?
Yep, looks good.
Okay, super. There we go. Okay, well, morning, everybody. So today I decided to talk about a topic that I don't recall discussing at Renal Grand Rounds since at least I started almost 5 years ago here. And yet it's one of the most common and most distressing symptoms for our patients on maintenance dialysis. And there is a new medication coming to market that we need to consider from a policy and advocacy perspective. So I thought, what better time to talk about CKD-associated pruritus? So I want to start with a case, a patient of mine from several years ago, who was a 70-year-old gentleman with end-stage kidney disease on maintenance dialysis, who was a former Marine, and he was a self-professed tough guy. But nonetheless, his itch was so severe that he could not tolerate sitting through dialysis. His wife said it was so bad that she couldn't sleep with him. He'd tried, he thought, everything from his own perspective. But the more he itched, the more he scratched. So he wanted to know, finally, when he said, I throw in the towel here, I've got to talk about this. Is this really common? Can we do anything about this? So we'll get back to him a little bit later. So by way of aims for the rest of the talk today, I want to talk a little bit about CKD-associated pruritus, aka uremic pruritus, how common it is, how distressing it is, how under-recognized it is, and really dig into a little bit what we know in terms of treatment, what the FDA has approved recently, future options worth understanding, and how to kind of fold this into the current care system. I always think it's good to go back and think historically, which helps us to go into the future. And yes, I'm going to talk about Dante's Inferno. So Dante's Inferno is part of Dante's epic poem talking about the various gates of hell and the 9 circles therein. And the 8th, closest to the ultimate 9th circle, is that of falsifiers who were punished by the burning rage of fierce itching that nothing could relieve. So we know that even back in the 14th century, this was very distressing. But it wasn't until 1660 that Samuel Haffenreffer defined medically an itch as an unpleasant sensation that provokes the desire to scratch. And people feel that this evolved to protect us from the various effects of insect bites, whereas you felt the itch and the scratch occurs to try to get some of the poisonous materials out of the skin from being absorbed. When you think about how itch is described, you can describe it as standard versus general, standard being solitary, acute versus chronic, with chronic being more than 6 weeks, contagious being the idea that you hear about itch or see somebody itch and then you result in itching. Maybe you're doing that right now. Psychogenic, the concept that people feel that there's something on their body resulting in an itch that's not really there, and uremic. So moving back to the more kidney-centric issues, let's talk about uremic pruritus. So CKD-associated pruritus. The clinical diagnosis felt to be itching directly related to kidney disease without another comorbid condition, but really it's multifactorial, as all of us know for patients that we've seen before, typically bilateral, symmetrical, variable in intensity, and you may or may not have skin lesions, but if you do, you can see, and here's a picture, acute excoriations, but there's also chronic changes that you can see with hyperkeratotic nodules, scars, prurigo nodularis. So Might be helpful, I thought, not to go through tons and tons of different studies, but rather to look at, because we have so much to talk about, I wanted to talk about one pooled meta-analysis of 42 studies. The authors actually really dug deep. They found initially almost 7,000 publications that had something to do with CKD and pruritus. They eventually screened more deeply, over 150 studies, and came up with these 42 with almost 12,000 patients. And the overall prevalence was felt to be somewhere around 55%. That included people that just had an occasional itch at least once a month. Although some studies have implied that pruritus in hemodialysis patients is more severe than PD, at least in this meta-analysis, they found that it was equivalent no matter what kind of renal replacement therapy you were undergoing, similar between men and women, and they couldn't necessarily rule out other causes in all the studies. So I thought it was very interesting to look into the various strong associations that they found in these various publications, which included an impaired quality of life, poor sleep, much more severe depressive symptoms. And these are ongoing studies that we have, as many of you are well aware, in our environment on sleep and depression. So I hope we're thinking about itch as well. And there was one study that was pretty well done that talked about increased hospitalizations and mortality back almost 20 years ago. So when we think about pruritus in maintenance hemodialysis patients, you could actually look at various time frames from the DOPS trial. And over time, you actually have a decreased prevalence of CKD-associated pruritus from various waves in the DOPS, but still, no matter what time period, although it has been decreasing, you're still seeing that over 2/3 of patients on maintenance hemodialysis reported some form of itch. So, you know, the prevalence is decreasing, but probably remains underestimated. There was this really interesting evaluation published in 2017 that, you know, almost 70% of medical directors and dialysis facilities underestimated the prevalence of this in their patient population. That 17% of patients with severe, not just moderate or mild, but severe itch didn't report it to anybody. And lots of people with severe or increased amounts of pruritus don't even receive treatment. So 18% of patients with severe symptoms used no treatment, according to one survey that was done. And there's lots of variation in the use of unlicensed medications. We'll get into that in just a little bit. But, you know, where does this rank in terms of common symptoms? Yes, this is a very busy slide. But if you look at it, itch circled up here in green is the second most common in terms of overall reports. And it is, you know, right up there with fatigue, shortness of breath, and poor concentration. And then when we think about areas that we should be researching more, I like this slide about the prioritization of research areas from the SONG initiative. This is the Standardized Outcomes in Nephrology initiative that tries to establish a set of core outcomes for trials and other research. And yes, itching comes out in the third outer tier. So the first tier, the core outcomes, is critically important. That all stakeholder groups should report in all trials. The middle tier is to be reported in some trials. And yes, the third tier is, you know, consider for trials. But nonetheless, if you think about what itching actually impacts, itching impacts, you know, some other things in the third tier: anxiety, stress, sleep, but also things in the second tier, like ability to work and other symptoms like depression and pain. And including on the first tier, which is fatigue. So it really is quite important. And so the SONG initiative, you know, talked to all kinds of stakeholders, but I also always like to go back to this publication by Dr. Fleith and many others who are on this Zoom call today, talking about patient prioritization of symptoms. You know, what really matters to our patients? Thinking back to Mr. D, our tough Marine that we talked about in the beginning of this talk today. And so even though the ultimate prioritized physical symptoms were these three: the insomnia, fatigue, and cramps, and as I mentioned, itch impacts insomnia and fatigue, you know, the identified symptoms, the physical symptoms, the pruritus was right up there, you know, certainly in the top 10, but kind of ranking in the top 5, 6. And then you think about the physical and mood symptoms. I mean, this really plays into so many of the aspects of things that impact our patients' care. So let's transition now and talk about some of the etiologies of CKD-associated pruritus, and then that will lead into what we can actually do about it. So, you know, a lot of times when you look back in the literature from the 80s and the 90s about this, they always talk about uremic toxins. So, you know, our patients underdialyzed, but one of the first things we always look about in the publications on this in terms of etiologies are the metabolic abnormalities. So CKD mineral and bone disorder, you know, is somebody hyperphosphatemic? What about hyperparathyroidism, hypercalcemia? How should we treat these, and how will it help with the pruritus? And then I just mentioned about quote unquote the uremic toxins. So is KT over V a marker? Should we be thinking about increased adequacy with, of course, your KT over V just being a very narrow measure of how we think about dialysis adequacy? Histaminergic reactions, well, antihistamines are rarely effective for patients with true uremic pruritus, but again, maybe there's a different aspect to a patient's pruritus, and so should you think about antihistamines? And then, of course, structural skin alterations. So many of our patients have xerosis. So what types of emollients and creams, and can you work with a dermatologist or the patient's primary care provider or you to help order and recommend various creams to help prevent dry skin, which helps overall. Systemic inflammation is there as well. This is where the UV phototherapy recommendations come into effect. And then thinking about alterations in the sensory pathways, the burning, the tingling, this is where we started to see the recommendations for the gabapentinoids. I have another slide about that in just a little bit. And then the opioid receptor dysfunction hypotheses, thinking about mu receptors and kappa receptors. And there's been some prior success in modulation, such as nalfurafine, which impacts kappa receptors at a proportion to mu receptors. And for those of you, and this certainly includes me, that hasn't studied opioid receptor effects and how it blocks or stimulates pain relief, here's a little figure for us. So, you know, mu receptor activation is blocking, the blocking of the mu receptors is felt to potentially help with pain relief, and stimulation of kappa receptors are also felt to help. So if you had some medication that could do one of those two or both, perhaps that would help to minimize pruritus. I want to talk a little bit, and I know this is making me itchy. There are randomized control trials looking at the gabapentinoids that have actually shown some success of them to treat uremic pruritus. Of course, there's not an FDA approval for it for uremic pruritus, but it is something that we have in our armamentarium. And except for these, you know, current evidence is for treatment is pretty weak. There's small sample sizes in these studies. I'm not going to go through all of them. I have some listed below in terms of references. There's a lot of bias, including selection bias, flawed methodology. But I want to remind all of us that gabapentin and pregabalin use is really associated with a lot of adverse outcomes among hemodialysis patients. If you just think about it, you know, I have increased altered mental status with various doses, increased levels of falls, increased fractures associated, so they should really be used judiciously. And increased research is warranted to think about optimal dosing. This is actually something I used in my patient, and we had to decrease his dose because he started to have altered sensorium. So there are really a lot of, there are very limited treatment options. A lot of off-label therapies are sometimes ineffective. You think about the different etiologies, side effects can be frequent. And there's limited available therapies in the US. I'll go into the one currently FDA approved therapy, but back in 2015, in looking through the literature, I found something on the Renal Fellow Network, which, you know, I recall 5 years ago, it's kind of how I thought about my uremic pruritus management. You know, you excluded other causes of pruritus. You thought about all the etiologies that we listed on the slide that we just reviewed. You assess them for the severity. If it's weak, you think about, emollients, moisturizing, oil baths. And then if you're starting to think about more moderate to severe symptoms, how can we provide appropriate doses of dialysis and adequacy? And then thinking about, should we use gabapentinoids? How about UV phototherapy? I have never used charcoal, but it was something there. And then thinking about altering the opioid pathways. So this is where I want to dive into new treatment options. So for all of you who have read a little bit about difelikefalin, I'm going to elaborate a little bit more. So this is something that really snuck into the scene. There was a publication that came out in 2020, that at the beginning of 2020, the New England Journal of Medicine, just as the pandemic hit. And I think that people weren't really paying attention to it quite as much. But initially, this medication was used to think about being a modulator of post-operative pain, chronic pain, and they recognized that it altered pruritus as well because it was a selective agonist of the kappa opioid receptor, just like I showed you before, that can actually decrease pruritus. It's peripherally restricted. It has very poor penetration for the blood to the blood-brain barrier, and has very high selectivity over other opioid receptors. So you don't have a lot of binding at the mu receptors. It modulates pruritus and CKD, may be a modulator of pain. And just so we know, for this talk, purposes of this talk, how you dose it, it's recommended thrice weekly at the end of dialysis by the venous circuit at a dose of about 0.5 mics per kilo. So you're talking, 50 mics for patients if you're going to dose it. So this medication was studied by Fishbane, Steve Fishbane and his group and others in this double-blind placebo-controlled phase 3 randomized controlled trial. There were almost 400 patients in it, which is very small trial, but not so small for the dialysis literature. Dose for folks who were in-center hemodialysis, maintenance hemodialysis patients who were dialyzing thrice weekly. And the primary outcome for this trial was the improvement of an itch scale, the WIN-RS, the worst itch numeric rating scale, which is scored on a 0 to 10 score, with 10 being the most severe itch and 0 being none, and looking at that over 12 weeks. So all patients had to have at least moderate, if not severe itch. And I just want to let everybody know that only about 4 to 5% of patients in various dialysis facilities were actually eligible to receive the medication in this study. And there was a substantial difference. So this 37% versus 18% of patients had a mean change from their baseline. So if you can see here, you had a decrease of average 3 points on this scale at 12 weeks, which continued over the course of the first half of this, over the first 6 weeks, that persisted through 12 weeks. But I do want to point out that placebo had an effect as well. Always love placebo effects. So, it was felt to be effective for the purposes of this study. And then you always have to ask, were there any adverse effects? And there were. There were a significant number of patients, more episodes of diarrhea in difelikefalin, the patients with difelikefalin, more dizziness and vomiting in the patients with difelikefalin. But the overall serious adverse event profile was relatively similar in terms of percentage. Again, it wasn't powered to detect mortality, but there were a couple of patients in each group that passed, and there were actually more falls in the placebo group, again, not powered for this. So as we move forward, thinking about new drugs on the scene, this actually came to the FDA in August of this year. And it was approved for consideration to be given a HCPCS number. I'll go into what that is in a couple of slides. So this actually may substantially benefit patients who have severe pruritus. But how are we going to support this? How are we going to pay for this? Because I'll tell you right now, although we have no idea what the pricing is going to be, why would they price it any differently than any of the new medications that have come onto the scene, which is typically on the order of a few $1,000s per month per patient? So this is on everyone's radar in the dialysis organization scene. I'll tell you right now, even before it was approved by the FDA, the large dialysis organizations didn't just have one person or one CMO paying attention to it. They had a team at the ready for this. And I know this because of conversations I've had. And right now you're kind of looking at the mighty Northwest Kidney Center's team for this, but we'll stand up a much larger team as things come onto the scene for this. I actually personally discussed it and presented the evidence for this to the CMS folks who had interest in this as part of the Nonprofit Kidney Care Alliance advocacy. Is it going to require oversight similar to other opioids? Probably not, at least in terms of the approval that the FDA gave in August. So, again, because it doesn't have penetration as best we know that's substantial into the blood-brain barrier, and it's really effective at the kappa opioid, not mu opioid receptor. And so then the question becomes, who's going to become eligible? The study that, was kind of the most robust one really was a very small percentage, like less than 1 in 20 patients in the facility were eligible for the study. But, if half of your patients have pruritus, do we want to consider it? So how is this, and as I mentioned, how is this going to be priced? So this is where I want to pivot just for a few of the last slides in this talk to bring in the aspect of politics and policy for a new bundled drug. So how does a new medication get to patients in dialysis? And how can we be good stewards of our resources to make sure that the right drug gets to the right patient at the right time, and that we provide the appropriate value? So I want to just provide a little overview of how a dialysis provider gets payment for treatment that they provide to a dialysis patient. So bundled rates for dialysis, which really covers everything for a patient, from the actual treatment to including the drugs they get, the labs that are done monthly, the supplies, and all the capital expenses related to furnishing dialysis treatments. On average, it's $255 per treatment. In Seattle, so it's adjusted for patient and facility level issues. So if wages are higher in one area, you get more. If they're less, you get less. Seattle, you actually get about a little over $280 per treatment, just to give you a little bit of a sense. But if you think about what that is, we're talking really about, $60 to $70 per hour to provide therapy, substantial therapy, which is really, bypass therapy, where you're providing blood flow rates of, 400 mils per minute with nursing and technician oversight. And if you think about this versus other therapies you provide for 4 hours and what you get reimbursed, it's very interesting to think about it. So as I mentioned, dialysis providers get this bundled rate. How does the government, and this is all Medicare rates for those patients that are covered by Medicare, how does Medicare think about bundling a new drug in? Well, they have to understand how it's priced. So for the first 2 years, it's not part of that bundled rate. You're actually given a transitional drug add-on payment for each of this. And we saw this with the calcimimetics when they just got bundled in. They look for 2 years on the wholesale price plus 6%. So dialysis organizations actually get paid on a fee-for-service basis for these medications. And then Medicare looks at how much it costs, and then they think about how much to add on to the bundled payment. And this again applies just to Medicare payments. And this is reminiscent, as I mentioned, to the calcimimetics. So taking this one step further, just want to give you a sense. Back in 2018, when we first had this TDAPA, this add-on drug payment, we were paying about $300 per month for patients to receive cinacalcet, about $30, just under that per pill. And Parsabiv, edelcalcetide, cost us what would cost over $2,000 per month. What Medicare ultimately decided, and again, not every patient gets these medications, as we're aware, they decided to bundle in about $9, which we just found out about, for the 2021 treatment. They ended up making it a 3-year TDAPA period. And so we had $9 added on, which is part of that $255 for every treatment. And if you think about that, that's adding on $120 per month for patients. But even if you had I'll tell you, I did the math myself, so I'll just tell you that if you had 6% of your patients on Parsabiv, right there, it starts to be a lot more money than what you're getting for your bundled rate. The other part of all of this is, let's see, sorry, I'm going to need to go to the next slide. Pricing for cinacalcet has substantially decreased because it became generic. So now we pay about $15 to $16 per month. This just tells you how crazy our system in this country is. We paid $30 per pill, and now we're paying half that amount per month for patients. So we still have that $9 per month in the bundle. It shows you basically, if you think that cinacalcet and edelcastotide aren't much different, and we don't know that they are, unless a patient can't tolerate that medication from an oral perspective. So as most of you know, if you need a patient on a calcimimetic, we are excited and happy to provide your patient any calcimimetic that you want. However, if you do want to use IV forms, it requires CMO approval. And I'm happy to always provide that. But it just gives you a sense of what we're dealing with. So as we think about this new drug that's coming into the scene, it's not approved yet because you need to have a special code called a HCPCS code. We'll probably get that in January, and then we'll figure out how it's going to be administered. So stay tuned. But the bottom line is we'll have this transitional period. However, if the medication that you're bundling in is in a functional category, you're going to say, what's a functional category? I'll show you on the next slide. Then Medicare may not add any bundled payment in ultimately after this 2-year period. And here are the functional categories that Medicare considers when they think about things like medications. This is a very busy slide, but I'm going to draw your attention to a whole functional category called antipruritics. And if you have any medication that is used for dialysis, for treatment for itching related to dialysis, which would absolutely include diphenhydramine, then ultimately, right now, the rules are that you wouldn't add on payment. So if you're going to have a medication that is $2,000 a month, which is, I have no idea how they're going to price it, but I can't imagine they're going to price it any lower than that. We'll see. This really puts us in a situation where you want to be able to provide your patient the drugs they need. Shouldn't the patient's needs drive the drug use, not the payment policy? This is why I entitled this slide, Patient Need versus Payment Policy. Maybe if you're in a value-based program, like some of the kidney care voluntary models, and if patient outcomes are going to be improved by the things that you do, that would be great. But what are appropriate drug pricing practices? This keeps me up at night. And it's something that all of us should be paying attention to as we think about advocating for our patients receiving maintenance dialysis, because the drug pricing practices in this country should not drive patient care. And so this is a discussion that hopefully all of us will participate in over the course of the next 6 months as this drug comes to be available. So coming back to our patient, the itch was driving him crazy. So I immediately talked to the patient. We ended up getting a dermatologist involved, and they helped us to prescribe some specific emollients. He began gabapentin. We actually dialed it up. He couldn't tolerate higher doses. He was on a little bit. He started some UV phototherapy. He tried not to scratch, and things improved mildly. But he continued to suffer. He was very thankful that it was improved, but it wasn't great. So in summary, I hope that I've shown you all that pruritus is very common among dialysis patients. It's associated possibly by uremic toxins, inadequate dialysis, dry skin, mineral bone disorders, first line therapies you're going to pursue for your patients, making sure you're getting optimal dialysis for your maintenance dialysis patients, controlling mineral bone disorders, emollients. Oh, it's easy for us to say avoid scratching, but certainly to let folks know. And then second line therapies, usually oral antihistamines are not going to be helpful, but it's important to consider. Gabapentinoids, if there's associations between other things, search if patients are suffering from depression, and then thinking about opioid receptor blockers as they're coming to the market. And then more than anything, which, has been my area of scholarly interest over many years, and I hope I've convinced you that it's really important to work with the medical system to advocate for reasonable ways to get new and innovative therapies to patients. And that's not just about difelikefalin or antipyretics, but for everything that we have. And so with that, I see that there are some questions in the chat. I think we still have maybe 1 or 2 more minutes.
Yeah, we got time for 1 or 2 questions. There's a question from Jonathan about whether FMC owns Cara Therapeutics, and I think the answer is they own half of it, but you can tell us.
Yeah, so Cara Therapeutics is its own company, but Vifor, which is part of FMC, is in tight partnership with Cara Therapeutics. So yes, Fresenius has essentially ownership stake in this medication.
Any other questions for Suzanne? I have one question, Suzanne. So during the TDAPA period, in which organizations can bill using a fee-for-service model for the drug, how much above the manufacturer's price can the dialysis organization charge? Like, how much can they make from that medication?
So great question. Typically what it is, it's wholesale price plus 6%. So I will tell you right now, when you go back to what happened with etylcalcetide, dialysis organizations made a lot of money over the 3 years. It ended up being 3 years for TDAPA over that period. But as soon as it got bundled in, what do you think dialysis organizations then veered? They did their best to help nephrologists not prescribe the medication. I will tell you that at Northwest Kidney Centers, we started from the very beginning in conjunction with the Medical Executive Committee, being good stewards for the system. And we didn't actually have etylcalcetide as part of our armamentarium for the first 6 months because we were very concerned about some of the data about hypocalcemia and thinking about cardiac effects from some of the early studies. And then we brought it in very slowly, not thinking about payment policies. And we've landed in a place that has been very successful for that medication. And I think, again, it's a very good lesson learned in terms of trying to bring this medication in appropriately. Unfortunately, we don't have an oral equivalent of difelikefalin, but we have other things. But nonetheless, I think this brings to light important symptoms that we should be paying attention to for our patients. So thanks for that question, Matt.
All right. Well, thank you, Dr. Watnick. Much appreciated. There is a tip from Dan Lamb in the chat. Liquid gabapentin will allow you to use very low doses to avoid sedation in particularly sensitive patients, like elderly patients.
Great tip.